You're in for a treat, okay? When I got here and I happened to meet a good colleague, okay? And I have been absolutely pleased to have patients who have not only seen him, but have gotten better, okay? And what he's gonna talk about, he's in a unique specialty. Let me give you a little bit of background, Dr. Ahmad, that graduate after he finished up medical school, he then went to the University of Miami where he did his residency in physiatry. All right, physiatry is rehab medicine, okay? So it's really a very interesting specialty, so hence the name physiatry. And he went on and further studied stem cell and regenerative medicine, which is really where we are heading in our society today, okay? If you look at a lot of what we're able to do, the fact that I can do genetic testing, we can do just tremendous things that we have available that we didn't have at one point within medicine. And now that we're able to do like the Galleria test, when that came out, and that was a marker just to determine, 50 or 60 different cancers, right? I mean, it's just incredible. But he's gonna talk and take it one notch up, okay? I'm gonna give you an example. I've had patients who have been seen that were told they needed a knee replacement, right? And some of my patients have been skeptical. They didn't want to do it. It was hurting, but they just didn't feel that it warranted an immediate, get in there and replace it. He's going to tell you about what he does with stem cells, and he's going to talk about regenerative medicine. And the most important thing is, every patient that's come back, okay, has had, number one, nothing but great things to say, all right? He cares just like we do. So in fact, we've always extended the WellcomeMD. He's very much, when he treats his patients, the care and concern that I get back to me from all of the patients that have seen him have said the same thing, okay? And tonight we're just very grateful that he took the time out, and I wanted him to come on in and talk to you about this, okay? And for those of you that couldn't be here, we're glad that you're watching this, and this will go out to all the membership and to other people that need it, and we look forward, again, calling the office and asking questions, okay? So I'm gonna give it over to Dr. Ahmad, and he's gonna tell you a little bit more about this. So thank you.
All right, well, thanks for coming, and like Dr. Klein talked about and mentioned, we're gonna talk about regenerative medicine, all right? And I'll go through an overview of it, and at the end we'll answer any questions you guys might have. So, I thank you to Dr. Klein. He's been, a big proponent. Luckily, I've been able to share a few patients with him. Luckily, we've got some good results. So, I appreciate the invite, and also with Giovanni also setting everything up and, inviting everybody. So about me, like Dr. Klein mentioned, I founded Advanced Sports and Spine. It's a few doors down, just right down the hallway. I started about 8 years ago with Advanced Sports and Spine, and then we started Stem Cell Carolina as well because I wanted to bring regenerative medicine as well. I did some in fellowship, and I'll get into that. But there was this gap in the healthcare where I felt like personally I was doing a steroid injection and then sending them to surgery, and there wasn't anything in between. And I knew that from fellowship training that regenerative medicine was an option. So we started Stem Cell Carolina, like I said, about 5-6 years ago, okay? So that's a few doors down as well. And I'm board certified in physical medicine rehabilitation, and my fellowship training is in interventional sports and spine medicine. So I did 4 years in PM&R and then the extra year training, just focusing on doing image-guided injections, things with ultrasound, fluoroscopy, anything from neck to toes, joints, tendons, nerves, ligaments, whatever. So just a little background in PM&R, and I think this is important because there's a lot of clinics around town that do regenerative medicine. And what PM&R is, stands for Physical Medicine Rehabilitation. Another terminology for it is physiatry, not psychiatry. I get confused with that a lot. It's not psychiatry, it's physiatry. And what that is it focuses on getting patients back to a functional status, right? It's all about quality of life, not necessarily quantity, but quality. So what we focus on when PM&R was created was after World War II, with a lot of soldiers that came back that had injuries. They came back and they had a major surgery. The surgeon's like, all right, nothing else for me to do from a surgical standpoint. Go to your primary care doctor. And it was a little bit out of the realm of what primary care doctors can do. So they needed to create another specialty that could focus on the traumatic brain injuries, the spinal cord injuries, the knee replacements, the hip replacements, the spinal injuries, anything that came with a bunch of sequelae after that injury. And that's where PM&R was created. So it's an inpatient specialization and an outpatient specialization. I do everything outpatient, but my training was both inpatient and outpatient. Inpatient, I dealt with spinal cord injuries, traumatic brain injuries, status post spinal fusions, Cotter-Quine syndrome, etc. So it's a wide array of musculoskeletal and neurological disorders that we dealt with. So again, it's a holistic approach. We look at the whole patient. Somebody has back pain. Is it just because of a spinal problem, or is their gait abnormal? Why is the gait abnormal? Is it a knee problem? Do they have flat feet? Do they need an orthotic, right? It's looking at the whole picture, just not focusing on one thing, and you treat the whole patient. So that's a big philosophy of PM&R. Another thing is multidisciplinary approach, right? So I have my training, I'm comfortable with my training. Unfortunately, I don't know everything. And that's when you reach out to the experts, your physical therapist, your occupational therapist, your nurse, your surgeon, your primary care doctor. And we work together as a team. Definitely in the inpatient setting, that's how it works. In the outpatient setting, we're constantly talking to our therapists, physical therapists, getting feedback on how our patients are doing after this procedure, okay? Also, just, the increased mobility, pain management, all those things that kind of come in with this specialty. So, regenerative medicine. Regenerative medicine is a relatively new branch of medicine, okay? And is focusing on repair, replacing, or regenerating damaged tissue to try to restore a normal function. The big thing about it is that this is previously conditions that we weren't able to treat or cure that now we have the potential to do so. So, what is regenerative medicine? It encompasses a lot of stuff. There's PRP, there's stem cell, there's things like biomaterials and tissue engineering, like skin grafts or valve replacements. There's autologous stuff, there's homologous stuff, animal to human, human to human, embryo to adult, etc. All that falls under regenerative medicine, okay? So we're going to strictly talk about what I focus on in regenerative medicine. The main, again, it's harnessing the body's own healing power, okay? It's been around for a while, right? Since the 1960s probably is when stem cell was first noticed as something that could be used for regeneration, right? Germany started doing a lot of research on PRP and platelet-rich plasma probably in the 1980s. A ton of athletes, professional athletes, have gone overseas. I'm sure everybody knows Kobe Bryant. He went over to Germany several times for his Achilles tendon. Dwight Howard did his shoulder. He was the center here for the Hornets. A lot of this was before it became more popular in America. Here, I would say, we started in my residency, we started doing a lot of research on PRP, and that was in 2010. And then fellowship 2014 is when we started doing a lot of adipose-derived stem cell, bone marrow-derived stem cell, and PRP, platelet-rich plasma. So it's relatively new, right? And I would say in the last few years, it's gotten very popular just because of media and probably social media and stuff like that. So why do we need regenerative medicine? And like I mentioned before, This is an option to potentially heal a previously untreatable condition. It has the potential to repair, regenerate tissue. It has less side effects. Okay, can you see my blocking here? Okay. And other options like steroid or viscous supplementation are temporary solutions. And this is something that's giving a more permanent option, or at least a longer option of relief. So current uses, again, of regenerative medicine. In regards to cancers, there's a lot of types of different lymphomas, leukemias that are done with cellular type of regenerative medicine, the hematopoietic cells. There's neural cells that's being used in things like cerebral palsy or spinal cord injury, previous stroke patients, multiple sclerosis, things like that. There is the tissue engineering, that's like skin grafts for like burn victims and things, even some type of valves, heart valves. So what we focus on, again, in my office is the PRP, bone marrow derived stem cell, and adipose derived stem cell, which is the mesenchymal stem cell. And we mainly focus on musculoskeletal conditions, arthritis, tendonitis, ligament tears, cartilage defects, stuff like that. So, one branch of regenerative medicine is PRP. What is PRP? PRP stands for platelet-rich plasma. Platelets are a cell that's in our whole blood. It's a vesicle. It carries a ton of growth factors. What we do is we draw the patient's blood. It's your blood. We draw it, we get a lot of it, and then we extract all the platelets out of it. So that's what gives us the platelet-rich plasma. Platelets is what our body uses to heal itself whenever it's injured. If you cut yourself, you injure yourself, what goes there first are the platelets. Platelets go there, they stop the bleeding and they start the inflammatory process. They start the healing process, which can take several weeks to several months. It goes in stages, and platelets is what starts that. But it's not as simple as just going and getting a PRP injection. There's different types of PRP, that's what's important. There's leukocyte rich, there's leukocyte poor, there's PRP lysate. You can have different types of systems, different technologies. We use the Arthrex Angel system. There's the ACP system. There's older technology that just uses a gravity and it separates things based on density. There's things that uses light penetration, so it's more accurate at pulling out the platelets. You want 1 million platelets per ml. Then it's PRP. You don't want a couple hundred thousand. That's not PRP, and there's studies been done that have shown that. And I want to say, it's important because there are, unfortunately, regenerative medicine is wide open. It's not FDA approved. It's not controlled by anybody. So there will be some clinics that may not give you or not provide the best product, right, or the best PRP. Okay, so it's important to know, or even if you are somewhere, to ask these questions: what type of PRP am I getting? If it's a joint, am I getting leukocyte poor? Am I getting leukocyte rich? These are important things to ask. So what does PRP do? Like I said, platelets are responsible for healing. They're responsible for starting the inflammatory process. So that's what we're getting, that high concentration, and injecting it to the problem site. The problem site could be anywhere from a knee to the neck to a shoulder to the ankle, right? It's anything. It could be a tendon, soft tissue, or it could be a joint. It could be hard tissue. It reduces inflammation, reduces pain, reduces swelling. It's been shown in studies to improve function. Okay. A great thing about to improve function. Right. To improve mobility. Right. Also, like I said, it's taken from you. It's taken from the patient, injected back to the patient. Very minimal side effects. Actually, luckily so far, knock on wood, in my office, we haven't had any reactions or any serious complications, right? And it's minimally invasive. We're not cutting, we're not doing any suturing, we're not doing any general anesthesias, local anesthesia. It's a very low risk procedure. So, like I said, the platelets it's a vesicle that carries a bunch of growth factors. There's about 30 growth factors in a platelet. It cracks open and releases all these growth factors. The most important are the ones I have listed here. They're on your little sheets as well, and they all do different things. You guys might know them as peptides, you might know them as secreting proteins. They all fall under as growth factors, and they help communicate with the immune system to regulate the inflammatory process in the immune response. So this is what communicates with your immune system to tell you, oh, this is an injured tissue, this is a sick tissue, this is a virus, this is a bacteria, whatever's going on. So these are the guys that are responsible for initiating and controlling everything. So we're providing that in a robust concentration where the problem site is to initiate the healing and this whole inflammatory process. The things that they'll do is listed here on the bottom. Like I said, it can stimulate new blood vessels, encourages cell growth. The blood vessels important. Things like a knee have very poor blood supply, right? So this provides the knee with the nutrients it needs to help provide heal itself, which we didn't have that capability even 10 years ago. So what are stem cells? Stem cells are undifferentiated cells. They're baby cells, okay? Not necessarily from an embryo, but just an immature cell that hasn't grown to adult cell. It hasn't matured yet, okay? There are different types of stem cells. There are adult cells that have matured that they can take into a lab and they can mess around with the genes and they revert it back to the immature cell. That's what the induced pluripotent cell is. And as a mesenchymal stem cell, the reason why that's capitalized is that's the one that we do in our office, okay? And then there's the neural cells, the epithelial cells, the hematopoietic cells that deal with blood disorders or neurological disorders or skin cartilage. In regards to the mesenchymal stem cells, that's the one that I'll be mainly talking about, okay? That is a type of immature stem cell that has the capability to turn into an adult cell that has a specialized function. It can turn into a bone cell, a cartilage cell, a tendon cell, or whatever. So whenever the cell or tissue is injured, the platelet tells the stem cell to come here. Stem cell recognizes where it's at in regards to all these growth factors and changes to that cell and replaces that injured cell. And then it has the option to replicate. It can divide, so you have one cell, then you have two, then you have four, then you have 8, and you have 16. It has the potential to replicate. So where do mesenchymal stem cells come from? Two places, bone marrow and adipose. If you get a bone marrow derived stem cell that's taken from the back of the hip, which we call the PSIS, the posterior superior iliac spine. It's just that hard bone right in the middle of your lower back. You can also get it from the femur, the thigh bone. You can also get it from the lower leg. The posterior iliac spine, posterior superior iliac spine, PSIS, is the most accessible. It's very well tolerated, so that's usually where bone marrow derived stem cells taken from. In regards to the adipose stem cell, it's usually taken from the flank or the love handle. Okay, depending on the type of condition you're treating will dictate what type of stem cell you want to take. Right? Bone marrow is very thin; it's about the consistency of blood. Adipose is thick, about the consistency of pudding. It's also very sticky, so it's ideal for large joints, knees, shoulders, hips. Bone marrow we use for the back. If I'm doing a degenerated disc, for example, we'll do bone marrow derived stem cell into the disc. Small joints in the back with the arthritis, they're very small. I can't fit adipose into it. Okay? We have some background music right now as well. So as mentioned, this is used to treat different types of soft tissue injuries, cartilage defects, arthritis. There's a ton of things that this can be treated. I've also done carpal tunnel syndrome, ulnar neuropathy. We've seen like little league pitchers with ligament tears in their elbows. cervical radiculopathy, pinched nerves in the neck, pinched nerve in the back. So there's a lot of conditions that can be treated with this, with varying degrees of results, and I'll dive into that. So I kind of touched on this already, so I won't spend too much time, but it's essentially just kind of talking about what stem cells do again, right? And it's, like I said, they differentiate the different types of specialized cells, and they can replicate. They replace damaged tissue, cartilage, bone, tendon, ligament, etc. They release those cytokines, which is a type of growth factor, which you mentioned, that helps regulate the immune response and the inflammatory response. So I won't spend too much time on that one. With this, an analogy I use with patients a lot is, imagine you're a gardener and you have a patch of grass and you want to fix that patch of brown grass or dead grass. PRP is equivalent to getting fertilizer, right? It's putting fertilizer down that area, providing it all the nutrients and whatever is there for it to grow back. Stem cells like going to Home Depot and buying a bag of grass seeds and coming down and putting down grass seeds in that brown patch, right? So anytime you put seeds down, you put fertilizer down, right? So anytime we do stem cell, we do PRP with it. Or you can always just do PRP by itself, right? You can just do fertilizer, or you can do seeds with fertilizer. And it's dictated by how severe the condition is or what you're treating. So again, just to reiterate the advantages of regenerative medicine, right? It's an alternative to surgery, right? It's less invasive, it's natural healing. We're using your own body to heal itself. Nothing is added to it. We just take out the stuff we don't need, right? But it's all we need is the platelets, or all we need is a stem cell, and that's what gets re-injected. And it has a potential to last for a longer time. Depending on what you treat, it can vary between 1 year relief, epidural injections for sciatica are about 18 months relief, stem cell for like osteoarthritis in the knee, a mild OA, you're talking about 5 to 6 years relief. PRP for lateral epicondylitis, tennis elbow, golfer's elbow, it's pretty much curative in about 90% of the cases, right? So if it's a small tear, ideally they probably just wouldn't come back, right? So it's a great option for a lot of things, and we'll get into that more. So I'm talking about all the pros, we'll mention some cons, right? In the US, it's not FDA approved. It's considered experimental, okay? So that's why it's not covered by insurance. So it's an out-of-pocket expense, right? The only two insurances that were covered is workers' comp, and if you have the insurance through the VA, TRICARE. And TRICARE will cover mild knee arthritis, and they'll cover tennis elbow, lateral epicondylitis. So those are two things covered by the VA. Workers' comp will cover a lot of stuff. All the other ones considered it experimental.
I'll just say this, that because the VA is doing it, the DoD's TRICARE is doing it, it's getting to the point where the insurance companies are feeling the heat. And I imagine it's only going to be a little bit more time before they have to capitulate. Because if we can save somebody from having to go into a knee replacement situation and absolutely get a couple of years of quality, isn't that worth it, right? So I mean, it's just a matter of time, and there are too many patients that are complaining now, and they're complaining to the right areas, so it's a matter of time.
And more research just needs to be done for the long-term benefits. Like I said, it's relatively new in the US, so a lot of studies are out to about 5 years. There aren't studies out there that's talking about, okay, what happens 30 years from now, right, or 20 years from now, right? There hasn't been that longevity of a study, right? So some of the conditions that are treated, again, there's a ton of them, right? Tendons, ligaments. I did an ACL on a guy. He was going to have surgery. He had a partial tear of the ACL. He's fine. He's back playing soccer. Like I said, a bunch of pictures for ligament tears, carpal tunnel syndrome. Rotator cuff's very, very common. Like I said, the most common is knee OA. We done lumbar spine. I had a lady come down from Ohio. We did a couple discs in her. She's doing good, like very well. She's not going to go with surgery. I've done a lot of different conditions. I don't want to name all of them, yes, ma'am.
What about varicose veins? Will that get?
So I don't do it for varicose veins.
Okay.
No, I don't do it. I have done it for peripheral neuropathy. Actually, one of your patients. So we done it with PRP for peripheral neuropathy, and he had about a 50% reduction in his numbness and tingling. So in pain management, you consider 50% a success. So I'll consider that a success. So right now, again, there's a lot of studies going on. There's a lot of research in this field. There's 5,000 active clinical trials as of when I looked it up, which was last week. So 5,000 trials on PRP, stem cell, different types of stem cell. And about 3 years ago, to kind of mention what Dr. Klein was saying, there's a ton of positive research out there for certain conditions, right? Especially mild knee OA and for lateral epicondylitis. They did 31 studies in 2021 on the knee for regenerative. This was stem cell and PRP, and 84%, or 27 out of 31 are positive. Had only 4 of them said it didn't work. I mean, that's really good when it comes to, and these are level 1 trials. So these are the double blind, these are like the best studies you can do, right? And 27 out of 31 said that PRP essentially worked. Or regenerative medicine, sorry. So PRP and stem cell. So just all the research that's been done, again, knees, low back, elbow, shoulders, varying degrees of relief. Depending on the severity of the knee OA, the more severe it is, the less success rate it is. It varies between about 65% to about 90%. More severe knee OA, you're in about 65% mark. It also depends on what part of the knee is affecting. Is it the inside of the knee joint, the outside of the knee joint? Is it affecting the patellofemoral joint behind the kneecap? Those all have varying degrees of success as well. Elbow, the tendons, like I said, it can be curative for those. There's potential healing there. But it's not great success for everything. It's very difficult to treat ankles and, for the lower extremity because people are weight bearing with soft tissue, right? So the thing that's hardest for me to treat is plantar fasciitis. It's probably it's a coin toss, right? It's about 50-50. Some patients do well, some patients don't, because the thing about PRP, like we were talking about, it induces inflammation, right? So it's very important to rest that tissue to give it time to get past those early stages of inflammation and the healing. And it's very hard to tell somebody, hey, stay off your feet for 2 weeks, right? So plantar fasciitis is a little bit more difficult to treat. Let's see, what's next? So our data, very simple data, just from my clinic. We just ask patients at, before the procedure, then at 6 weeks, then at 12 weeks, how they're doing. In general, our success rate is about 75%, right? So at 3/4 of our patients report a 50% reduction in pain or a 50% increase in function. Okay, and we base function on how long can you sit, how far can you walk, how long can you sit, right? So different things of activities of daily living and an improvement in that function. And the far majority of people would say they would do it again, right? They would do it again, or they would tell a friend or family to do it again. One of our biggest referral sources is word of mouth, right? If somebody telling their parent or their spouse or whatever to come. So I gave you guys a lot of numbers and a lot of data in regards to PRP, but I just want to just give you this as a comparison, right? Knee steroid injection, the success rate is 74%. That's on par with PRP or with regenerative medicine, right? The accuracy improves if they use guidance. So if they do an ultrasound guided injection or fluoroscopic guided injection, then it's a more accurate injection, and then the success rate goes up to about mid-80s to 85%. So even a cortisone injection, which has been around for years and is always the go-to, isn't 100%. So nothing in medicine is 100%. Hyaluronic acid, viscose supplementation, right? Somebody goes and does a steroid injection for the knee. They don't do well with it. The next step is a gel shot. They do a series of 2, a series of 3, 4, 5. I do those in my office, right? Patients do well with it, but again, not everybody. 60 to 70%, right? It's covered to do every 6 months, but studies show it doesn't last 6 months. It lasts about 4 months. So there's always that 2-month gap where your pain is back, and you have to wait those 60 days to do it again, right? So let's say you did the steroid, you did the viscose supplementation, you did the steroid, right? You go to your surgeon. Your surgeon's like, okay, we can do total knee replacement, or you can live with it until it gets so bad that you decide that you're going to do a knee replacement now. That's where regenerative medicine comes in. That's your option, right? But let's say you decide you bite the bullet and you go and you get your total knee replacement. It's still not 100%. On a total knee replacement, about 20 to 30% of people still have chronic pain after a knee replacement.
And that's something that led me to really, when you stop and think about it, and what the surgeons are never going to tell you is, there is this step right here, okay? And when you really think about, in my career, I have seen about 20 to 25% that has still ended up in chronic pain after a knee replacement. And when you ask them, would you do that again? In fact, they're going around and saying, don't ever get it done, right? Because they're in pain. So nothing's 100% like you said in medicine, but I will tell you this. When you look at the regenerative medicine that has happened, and again, in Europe, they've been doing this for so many years that it's almost shameful that American medicine just, started getting into it. But there's a lot of factors that drive that. But this is absolutely a wonderful step because of the percent that do well, okay? And before I came here, I had sent a patient and had, he failed on, this is when I was back in the DOD, he failed on the knee replacement. And when they started, and this is one of the reasons TRICARE had to capitulate, right? Because, they're looking at cost benefit overall with, so when they did the regenerative, let me tell you something, it just, it was a total different outcome, all right?
And he did that after the knee replacement
that
surgery?
answered my
so
question.
He did it after because it failed. And at that point, we kept pushing and saying, we need to do the regenerative, right? Now, there's pluses and minuses with that because the joint has been removed, but there's still inflammation, right? So even though you're not getting at the joint, the surrounding areas of that joint, which is where the pain, right? Remember, pain, I always say this, and pay attention immediately now, right? You can't ignore it. And when it becomes chronic, it's too late. So that's why I always say pain has to be dealt with. There's a reason. So that's why it does what it is actually intended to do. And when you reduce that inflammation surrounding that, because the only other option that anybody has is removing and putting in another one.
You got the post-surgical tendon healing and.
Yep. Yeah, as well.
Got questions.
Just as this being, hips do better than knees. Failure rate for a hip is about 10 to 20%. So total hips end up doing better than total knees. Also, kind of what Dr. Klein was mentioning, after you have a knee replacement, your options are pretty limited. They used to cover something called a genicular neurotomy, where you can ablate the nerves that go to the knee, and it gives you about 60% pain relief. But insurance stopped covering that last year, I think. So unfortunately, there are very limited options after knee replacement if you fall on that 20-30%. So just to touch on the cost, PRP. At our office, we use the Angel system. There is the ACP, which is the older system as well. That starts at about $1,000. Stem cell starts at about $5,000, depending on what's being treated, how many joints are being treated. There are I would say we're probably in the middle. There's some places more expensive, some places cheaper. There are cheaper types of PRP, platelet-rich plasma, that can be done for about $500. It doesn't give you the same concentration of platelets, so it's done in a series of injections, a series of 3, whereas in our office we just do 1, right? So different technologies and different concentrations of platelets, just to give you an idea of cost. But when you compare that to, and I'm just using a knee replacement as the option, obviously there's hip replacements and fusion surgeries and all that stuff, you're talking tens of thousands of dollars. If you have insurance, you have Medicare, it's going to cover 80%. Your 20% will be out of pocket unless you have a secondary. But then there's the cost of time, right? And how do you put a price on that, right? The total recovery for a knee replacement is about 1 year, right? The recovery after a knee injection is about a week, right?
There's something else to bear in mind that yes, there's no free lunch in this country. So Medicare, you will be socked with that 20%. But there's something else, and that is also what's not included that I always have to remind patients is the rehab, which is not just a couple of weeks and have a nice day. You're in rehab for a long time, okay? And when you look at this breakdown, it always amazes me once again. Why wouldn't you even consider, and I just say this to a lot of the patients, I think, do this part first, because there's always the knee replacement, right? That's always the option, right at the end. But when you look at that cost breakdown, and then there's tax, licensing, destination charge. I mean, he's giving you right, but there's all the other costs involved, right? So you have to look at that, and it's very expensive.
Well, that's your deductible right there.
Absolutely. So again, just in conclusion, it's another tool in the belt, right? It's not for everybody. It works for a lot of people. It's that non-surgical option to help with pain, improve function, improve your quality of life. And who knows what future leads? There's a ton of research out there. We use a certain system now. We are doing things a certain way right now because right now we believe it's the best. But 5 years from now, that might change, right? Data always changes, research is always out. So it's a very exciting field. It's a very exciting field. I think we have a video as well. Okay, there's some references. All right, so this is just the PRP process, just to give you guys an idea. It's just a simple blood draw, right? We take anywhere between 60 mLs to 180 mLs, depending on what we do. I did a girl's hip earlier today. She had a bunch of soft tissue problems. We drew 180 mLs, right? So we draw the blood, and then we transfer it to the centrifuge or the Angel system, and that tells us from there, there's a little computer. I'm like, okay, I want 2% leukocyte. I want 7% leukocyte. I want some platelet plasma. I just want the growth factors. Or, we can extract some red blood cells if you need to. And it'll separate everything based on weight, and then it goes through this little light thing, and that based on the density separates the cells further. So that's what the finished product is. You have 180 mLs of blood, and it goes down to a few mLs of platelet-rich plasma. And then we do all of our injections under guidance. At my office, if you have wrist pain, we're not just going to inject just the knee, just the wrist joint, right? You're going to see where the problem is. You're doing full workup. You're going to see, is this a tendonitis? Is there a scapholunate lucency? Is there arthritis? And you treat all those areas, right? So you want to make sure it's a comprehensive treatment. Everything's done under guidance, like I mentioned, either ultrasound or fluoroscopic guidance to improve the accuracy. That's a wrist injection I did in my PA. Did a couple years ago, and he actually says he's doing pretty well right now. He has no pain in his wrist. Achilles tendon, this one's a little bit more painful. I've done a lot of MMA fighters. For some reason, they have a lot of Achilles tendonitis. That is from kicking or whatever, and it's painful. But I'm sorry.
Leaping down off the ropes.
I guess so. I don't know what they're doing there, but yeah, this one we use leukocyte-rich type of PRP. So that's the process of PRP. And that's it. So, questions?